Hello, I am doing my anatomy stream, the last one, or not the last one, but the almost last one, right now, today. Interesting. It's going to be about the reproductive system, and then it's also going to be about the immune system, two-parted exam. So let's get into it. So, reproductive system, it is a couple of things about it. It is the only system that is not essential for life. It's dormant until puberty and has different organs and structures for males and females. Males will undergo spermatogenesis, which will produce 20 to 100 million sperm per milliliter of semen continuously throughout their life. And then females undergo oogenesis, but they're born with all the gametes they will ever have. 2 million primordial follicles at birth, and they have around 400 ova released during their lifetime, with one oocyte released during their time of their menstrual monthly cycle. So the male reproductive anatomy, you got the testes, which is the primary male sex organ. It'll produce the gametes and secretes hormones. Sperm will start here. So everything I read from now on, including the female reproductive anatomy, will be in order of where sperm travels. Next, you got the epididymis, which is where sperm matures and is stored. The vas or ductus deferens, which will contract to move sperm forward. The seminal vesicle, which will secrete seminal fluid, which is 60% of semen volume. If the seminal vesicle is blocked, then of course 60% of that semen volume is going to not be secreted. Then it also secretes fructose for energy and prostaglandin for secretion. Or contraction, sorry. And then the prostate glands will secrete prostate fluid and enzymes, which is 30% of semen volume. So, yeah. And then the bulbourethral gland secretes thick alkaline mucus to neutralize acidity in the vagina and also like in the male reproductive system as well. And then in the penis, the sperm will travel from the bladder to the ejaculatory duct, then to the urethra. The semen is made of sperm, seminal fluid, prostate fluid, and mucus, which is 2.5 milliliters total produced. Then now we're going to move on to the female reproductive anatomy. The vagina has thin walls and have rugae or inner mucosa. The cervix is the lower end of the uterus that is muscular and rich in connective tissue. The uterus is made of myometrium, which is smooth muscle and expels baby during birth, and also lined with endometrium, which is mucosal lining that sheds if no implantation occurs. The fallopian tube is where an ova gets fertilized. It has highly folded mucosa with ciliated and non-ciliated cells. The cilia beating and peristalsis moves the ovum to the uterus. Now, the infundibulum of the end of the fallopian tube has fimbriae, which is finger-like projections. And the ovary is a primary female sex organ, produces gametes, and secretes the hormone. All right. Okay, now we're going to look into the male reproductive system a little bit more. So the testes anatomy, they have seminiferous tubules, which make spermatozoa. This is 1 to 4 seminiferous tubules per lobule. So there's lobules that have 1 to 4, and they're separated by septum or septa. Leydig cells are interstitial cells, and they produce testosterone, and then Sertoli cells maintain the blood-testis barrier and support spermatogenesis, and then secrete inhibin and androgen binding protein. The retestis is where the seminiferous tubules connect to the efferent tubule. The efferent tubules leads to epididymis. The epididymis stores, protects, and supports sperm maturation and recycles damaged or dead sperm. This is organized into the head, body, and tail. The vas deferens transport sperm cells from the epididymis to the urethra. So how this is how spermatogenesis will work. So first you got this spermatogonium, which is a stem cell. Then you have mitotic division, which is will end with a primary spermatocyte. The first meiotic division will end up with a secondary spermatocyte. Now the second meiotic division will end up with a spermatid, and then the spermatid will become a spermatozoa, which is an immature sperm, and then again it'll become a spermatocyte. Okay, now hormonal regulation. Now we're going to talk about that. First, you have GnRH. GnRH is the gonadotropin releasing hormone from the hypothalamus. It travels to the testes via blood. Um, it'll activate two things. So the first thing it'll activate is the follicle stimulating hormone FSH from the anterior pituitary. This will cause the first meiotic division, high sperm count, and inhibin secretion, which will decrease the amount of FSH secreted. Sertoli cells will secrete androgen binding protein, and if that antigen binds with the protein, it'll allow for spermatogenesis and keeps testosterone levels high. Now, the second thing it'll activate is the luteinizing hormone. The luteinizing hormone is from anterior pituitary as well. So Leydig cells secrete testosterone and allows for development of the genitalia and male secondary characteristics at puberty, libido, maintenance, bone, and muscle growth. So negative feedback loops with testosterone will lower GnRH and LH, which lowers testosterone. Inhibin will lower FSH, but not GnRH. So that's what inhibin does. Okay, now moving on to the female reproductive system. The oogenesis. So first, it'll start with oogonium, which is a stem cell. The mitotic division will end up with a primary oocyte. The first meiotic division and the secondary oocyte. A second meiotic division plus ovulation will end up with a ovum if fertilized. The second part of oogenesis, it'll start with a primordial follicle, which is at birth, and then at puberty, it'll turn into a primary follicle, which is a single layer of cells around that primary oocyte. Then it'll turn into a secondary follicle with 2+ layers of cells around the primary oocyte. Then it'll turn into a Graafian follicle with a large fluid-filled antrum. And then after ovulation, you'll have that corpus luteum, a degenerated follicle after ovulation. It'll secrete progesterone, estrogen, and vascularizes the endometrium lining. Sorry. It'll vascularize the endometrium lining and maintain lining in the first trimester until the placenta takes over. Now, ovulation is when the mature oocyte is ejected from the ovary to the fallopian tube. A follicle is basically an oocyte with granulosa and theca cells. The ovarian menstrual cycle is based on a 28-day cycle usually. Sometimes it's based on more. Based on a 28-day cycle, the follicular phase will be days 1 through 14, which is when the primary follicle to ovulation, and it varies. The luteal phase will be 15 to 28. This is from ovulation to corpus luteum degeneration, and this is 12 days, and it's usually set. Now, the uterine menstrual cycle is can be also based on a 28-day cycle. The first is menstrual, which is days 1 through 5, which is endometrium lining shedding, and it can vary. The proliferative phase, which is days 16 through 14, which is rising estrogen levels, will rebuild the lining, will also vary. Now, secretory is days 15 through 28, which is, again, 14 days. 13 days, and this is a set amount of time. It is when rising progesterone levels increases endometrium vascularization and prepares it for implantation. Now, your fertile window. So, your ovulation will always be 14 days less than the number of days in the cycle. So, that means, like, your first date of your fertile window is 5 days before ovulation if sperm lives 5 days. If the sperm will live 7 days, then the first day of your fertile window is 7 days before ovulation. And then the last day of ovulation will be usually 1 day after ovulation because sperm will live 24 hours. So, if you ovulate on 1 day and sperm lives 24 hours, then the last day will be 24 hours after ovulation. Okay, so hormonal regulation of the female reproductive system. So again, you have GnRH from the hypothalamus. It'll travel to ovaries via blood. Then you have FSH from anterior pituitary. Granulosa cells, they're kind of like Sertoli cells. They will stimulate follicle maturation, oocyte nutrition, and convert androgen to estrogen, and then also secrete inhibin. Luteinizing hormone from anterior pituitary will activate Theta cells, the like Leydig cells, and they will secrete androgen for conversion. When it's converted to estrogen, it'll stimulate endometrial growth. It'll also induce secondary sex characteristics, and it'll also maintain low blood cholesterol. Okay, so now we're going to talk about the whole phase cycles and what happens to the hormones. So early to mid follicular phase, or the first 10 days, this is when the GnRH will cause secretion of FSH, so the primary to secondary follicle maturation. It'll cause the secretion of FSH and LH. Again, estrogen from LH. And estrogen is low, will inhibit GnRH, LH, and FSH production via negative feedback. So at this point, things are rising a little bit, but it's more like kind of like a little bit steady because things are only like growing just a little bit. And so like everything is pretty much like the same, except you see kind of a slight rise in estrogen, FSH, and LH, but usually right now estrogen is negatively feeding back, so it's not a lot of action going on. Now around ovulation, this is when estrogen will increase because the follicles will mature and the estrogen will come from the follicles. So after 10 days, the estrogen will be high and feedback positively. This will increase GnRH and LH and FSH. So there's going to be an LH surge, and that LH surge will cause ovulation. That will be the cause of everything. So inhibin only suppresses FSH, so the FSH peak will be lower than the LH peak. So during ovulation, there's a high amount of estrogen and high amount of LH and FSH, but more LH than FSH because inhibin will be suppressing only that FSH. The estrogen will thicken the endometrial lining. Okay, now after ovulation, you got that luteal phase. The ruptured follicle will become a corpus luteum and slowly degenerates. It'll secrete estrogen, progesterone, and inhibin. This will negatively feedback on LH, FSH, and GnRH. So all of this will pretty much start to negatively feedback, not positively now. Progesterone will prepare and maintain the endometrium for implantation. And then growth of breasts and thickened cervical mucus to prevent sperm and pathogen entry. It'll also raise body temperature and peeing. So this is when it, pretty much LH and FSH start to go down from that peak. And then progesterone is starting to, progesterone is super high. But everything else is pretty much, going back to, normal. normal levels. Now, the end of the luteal phase is after about 12 days. This is when menstruation happens. So this is when corpus luteum will degenerate. There's a sudden drop in P4 P4 is progesterone. There's a sudden drop in progesterone, estrogen, and inhibin, and endometrium lining will shed. There's no negative feedback, so GnRH, LH, and FSH will start to rise again. So that's what it looks like. Now we're going to talk about basically the pregnancy. So at day 0, fertilization of an ovum leads to zygote in fallopian tube. At day 4, zygote develops into morula, which is a zygote enveloped into the zona pellucida, and the zona pellucida will prevent implantation. At day 7, the morula will hatch out of the zona pellucida into a blastocyst and implant in the uterus. The blastocyst has an inner cell mass, which is the embryo, and then the trophoblast, which is the fetal placenta of the organism. The cellular trophoblast is it'll surround the embryo, and then you have the syncytial trophoblast. What this is give me a second. It inserts into the endometrial lining and secretes proteolytic enzymes for implantation, and will also secrete human chorionic gonadotropin, which is HCG, which is similar to luteinizing hormone. This is a maintained corpus. It'll maintain the corpus luteum to secrete estrogen and progesterone. HCG is measured in pregnancy test. So yeah, since HCG is similar to LH, it'll be measured in that pregnancy test. So you got an ectopic pregnancy. This is when the implantation of the fertilized egg happens in the uterine tube, not the uterus. It has to be removed. Post-pregnancy hormones, prolactin is produced and secreted from the anterior pituitary. This will cause the development of the milk and mammary gland. Oxytocin is produced in the hypothalamus and secreted from the posterior and pituitary. This will stimulate muscle contraction for childbirth and also milk letdown. Now we'll talk about the development of the reproductive system. So there's different types of sex. There's chromosomal gonadal, which is testes versus ovaries. Hormonal, morphological, which is reproductive organs. Legal, behavioral, and gender. First, we're going to talk about male sexual differentiation. So at 6 weeks, bipotential or neutral gonad has the Mullerian, which is the future female duct, and the Wolffian, future male duct. So for males, the Y chromosome has the SRY gene, and the SRY gene will code for the testes determining factor. So for this testes determining factor, at 7 weeks, testes will develop because of that factor. So the testes will have Sertoli cells. Sertoli cells will have the Mullerian inhibiting factor, so the Mullerian duct will start to degenerate. And the testes will also have Leydig cells, and so Leydig cells will secrete testosterone, which will cause the Wolffian duct to become the epididymis, vas deferens, and seminal vesicle. So this is internal development. Testosterone will eventually will be converted to dihydrotestosterone, I think, which is DHT. DHT will be converted by that 5-alpha reductase, and it is more potent form of testosterone, and it'll develop the external genitalia. DHT will turn the urethral folds, which are neutral, to the glans penis, which is male, and then the labioscrotal cell swellings, which is neutral, to the scrotum, which is male. And then at 2 months before birth, testosterone will cause testes to descend to the scrotum. Okay, so cryptorchidism is when testes do not descend properly and do not form sperm properly, because it needs to be below body temperature to properly develop sperm. So this will lead to infertility and possibly cancer. Okay, so female sexual differentiation at 6 weeks, bipotential gonad has Mullerian and Wolffian ducts. At 7 weeks, no testes because no SRY gene. So this means the ovaries will develop since there is no SRY gene. And no testes will also equal no Mullerian inhibiting factor. So the Mullerian duct will develop into fallopian tube, uterus, cervix, and upper half or upper third of the vagina. This is internal development. No testosterone will mean the Wolffian duct will degenerate. No DHT means female genitalia externally. The unexistence of DHT will change the urethral folds, which are neutral, to the glans clitoris, and then the labioscrotal swellings to the labia majora. The Bartholin glands in females secrete mucus similar to the bulbourethral gland. Now we're going to move on to immune system, immune components. You got the organs connected by lymphatic vessels. First of all, let's talk about mast cells. Mast cells have histamine. That's all you need to know. And then tonsils are masses of lymphatic tissues. They remove pathogens from food and air. Lymph nodes are where lymphocytes encounter antigens and activate attacks. They have resident macrophages, which is WBC, that destroy microorganisms. Swollen glands will mean local inflammation or infection when the number of leukocytes increase in nodes. The thymus is where the T cells mature. The bone marrow is where the B cells mature. The bone marrow is also where, like the blood cells, like red blood cells and white blood cells, including natural killer cells and T and B cells, and platelets originate. The spleen will remove abnormal red blood cells, platelets, pathogens, and bacteria via macrophages. This will store the red blood cell and platelet breakdown products for when needed. You got two types of immune system. First, you got your innate immune system. So you have that first line of defense, which is fast and non-specific. Characteristics of the innate system, you got fever and physical or chemical barriers, including mast cells, which help with inflammation and is a tissue resident. Basophils, which aid in inflammation but circulate the system. Phagocytes, which are white blood cells that consume and destroy pathogens. This includes macrophages, which are free and wander tissues or fixed or that are confined to organ. Or you have neutrophils that move into the site of infection and then become phagocytic. Natural killer cells will induce apoptosis, which is cell suicide. Antimicrobial proteins will attack or destroy or deactivate pathogens. And then complement proteins will kill the pathogen directly or tag them for phagocytes. So, yeah. Now, adaptive, this is the second line of defense, which is slow and pathogen specific. Antigen presenting cells, these are macrophages and dendritic cells of the adaptive system. This will activate helper T cells and cytotoxic T cells from immature T cells, and then plasma cells from immature B cells. And it'll present pathogen antigens to T cells. Cytotoxic T cells, which is a cell-mediated immunity, will destroy the pathogens, and then B cells, which is humoral immunity, will release antibodies to destroy the pathogen. So, cytotoxic T cells, macrophages, NKCs, phagocytes, and complement proteins destroy the pathogen directly. That's the first type of immunity, and the second type of immunity. Now we're going to talk about innate immunity more deeply. So, a physical barrier will keep hazardous organisms and substances from entering the body. This will include the skin, mucous membrane, nose hair, and cilia, and the upper respiratory tract. The chemical barrier will include lysosomes, which is in tear, sweat, and saliva, gastric juice, skin and vagina acidity, and defensins, which are antimicrobial peptides secreted by membrane and skin. And then you have that phagocytosis. So how this happens is first you have the adherence of the phagocytes to the pathogen first. Then you have the pseudopods develop and envelop pathogen. This will form the phagosome. The phagosome will fuse with the lysosome, forming the phagolysosome. Then the lysosomal enzymes will digest the pathogen. Then the residual material will exit via exocytosis. When injury occurs, the immune system inflammation response is induced. Mast cells will have histamine, and the tissue macrophage will have cytokines. So both of these will lead to inflammation. This will lead to vasodilation and vascular permeability. This will then lead to neutrophils and monocytes moving to the area via diapedesis and engulf the pathogen. Clotting will then begin. Complement proteins will then form the membrane attack complex, which is the MAC. That's basically a pore, and that will lyse the pathogen. This will then cause inflammation again. And then APCs will engulf the pathogen, present the antigen, and then travel to the lymph nodes via lymph vessel, which is a one-way mini valve and is leaky when the pressure of the interstitial fluid is higher than the pressure of the lymphatic vessel. This will mature immature T and B cells. So APCs will cause that. After injury, inflammation, which is redness and vasodilation, swelling, which is fluid or protein leak, pain from prostaglandin, and pus, which is dying neutrophils, tissue cells, and pathogens, will ensue. Okay, so adaptive immunity. T and B cells, natural killer cells, macrophages, and major histocompatibility complex, or MHCs, are part of adaptive immunity. MHCs are on cell surfaces and present antigen fragments for T cell binding. MHC1 is in almost all cells, so this is once infected presence. It'll present the antigen to cytotoxic T cells. MHC2 are in APCs and are presented antigen to helper T cells, which then activate B cells, which then it'll activate B cells to plasma cells, which is humoral, and then T cells to cytotoxic T cells, which is cell mediated. They also activate NKCs and macrophages. The adaptive immunity activation, the cell mediated part. So first the virus will infect the cell. Infected cells will present the antigen on MHC1. The helper T cells will activate cytotoxic T cells, which bind to that antigen on MHC1. And then the cytotoxic T cells will secrete perforin, which forms a pore, kind of like the MAC, and then granzymes that enter the infected cell cause apoptosis. Now, the innate part of the adaptive immunity activation. So the macrophage will ingest the virus and present the antigen on MHC2. The macrophage will secrete cytokines, which activates NKCs, helper T cells, and cytotoxic T cells. Helper T cells will activate macrophages and NKCs, which will attack infected cells like cytotoxic T cells. Cytokines aid the inflammatory response. Lastly, you have the humoral part of the adaptive immunity activation. So helper T cells will activate the plasma cells, which secrete antibodies. Antibodies will bind to the virus, mark them to be destroyed by phagocytes and complement proteins. Upon secondary exposure, some T and B cells differentiate into memory cells and produce antibodies more rapidly for a faster and larger immune system response. Now you got the antibody and T cell selection. So first you got that stem cell. So the stem cell will lead to the pre-T cell made in bone marrow, then to the naive T cell that matures in the thymus, which is receptors. And then the pre-B cell will be made in the bone marrow, then changed to the naive B cell, which will mature in the marrow, which has antibodies. When B and T cells divide, each daughter cell has different antibodies for B cells and then receptors for T cells. So during maturation, you'll have the vetting and migration process. So first, the stromal cells in the bone marrow will present the self-antigen. If B and T cells bind to the self-antigen, the receptor or antibody is edited and the self-antigen is eliminated via negative selection. Now, if B and T cells do not recognize the self-antigen as foreign, there is no binding, and it survives and migrates to the lymph nodes, which is negative selection. Okay, so when is it positive and negative selection? Okay, the first one is positive. Positive is when B and T cells bind to self-antigen, and then the receptor antibody is edited, and the self-antigen is eliminated. So that's positive selection, I think. If B and T cells do not recognize the self-antigen as foreign, it'll be negative selection. If a B and T cell recognizes the self-protein but escapes the vetting and migration process, autoimmune disease will develop. So B cell activation. So B cells will bind to the epitope of antigen located on the virus. Antigen gets broken down inside B cells, which will present the antigen on MHC2. Helper T cells activate B cells, which will make antibody clones. Some become memory cells, and some become plasma cells that makes a lot of antibodies. So T cell activation, T cells either have CD4 or CD8 receptors. T cells with CD4 receptors bind to MHC2 of APCs and become helper T cells. And then T cells with CD8 receptors bind to MHC1 of infected cells and become cytotoxic T cells. So some pathology, acquired immune deficiency disease or syndrome is AIDS, and the treatment for this is antiviral drugs because it's caused by the human immunodeficiency virus, HIV, which destroys helper T cells. Lowered helper T cells is a lowered cytotoxic T and plasma B cells, which means suppressed immune functions. HIV is a retrovirus, which produces DNA from its viral RNA. Then it'll insert it into healthy cells to produce viral RNA. Autoimmune disease can be treated by corticosteroids because cortisol is anti-inflammatory. This is caused when the immune system, which is cytotoxic T cells and antibodies, recognize your own organs as foreign and attack them. First, you got T1, insulin, type 1 insulin dependent diabetes mellitus. This is when pancreatic B cells are destroyed and there's low to no insulin production. Then you have multiple sclerosis. This is when the myelin of the white matter of the brain's spinal cord is destroyed. And you have that will disrupt the communication between the brain and body. So, for example, you will have vision loss, which is pretty cool. Then you have rheumatoid arthritis, which is when the body will attack the joints and cause inflammation. That's basically it. Let me search up real quick. Positive. Okay, yeah. So positive is when they recognize the self protein, and negative is when they don't. Okay, bye.